So if you see this fracture, I'm sure most of us would be probably very happy to see this fracture in our OPD. And as my old good friend Dr. Paude, he would, most of us would probably say maza aega. So because these are very accessible fractures, they are displaced, and as our basal instinct is in orthopedic surgeons, we should try to fix it. So the fixation is very easy. It's a very subcutaneous bone. You expose it, and you can put the plate, align it without bothering about what is underneath. Over the moment we land on the bone, we are very happy and ecstatic, and that is how we fix it. So, but that is not the story. So once you fix it, then the trouble starts, and then you are responsible and answerable to your patients as well as your own conscience, whether you did the right job, whether the fixation was necessary. So these things tend to blow apart. So then the fixation fails. You can see it here, what simple fracture which ultimately failed, and the implant started coming out. So, and unfortunately this is a very subcutaneous bone, so your failure is very evident. You can see that as soon as it starts happening, because your plate starts becoming, and it had to be removed, and thank God, God is great always. Even the moment we removed it, the fracture started uniting. So was it necessary from the beginning? So most clavicular fractures heal uneventfully, without serious consequences, with non-operative treatment. That is my belief, and generally in the olden times, means in last 10 years ago, it was a very clear thing that relatively agreeable and cooperative bone, clavicle it is, and it requires little more than symptomatic treatment. So the dictum that even if the two ends are in the same room, probably they will unite. It may not hold true today, because the goals have been shifted. So if you want to get into trouble, that was Professor JC who said that you want to trouble, then fix a clavicle. So primary operative intervention is meddlesome and only makes things worse. So this is somebody who has been treated non-operatively, and you can see the function. Although there is some bump which can be seen here, which is not very visible. Otherwise you probably would have a big scar there, unsightly scar, and for ladies that would be very important. So a small bump or a unsightly scar, that is what you probably thought of. So simple sling, the treatment, if you treat it non-operatively, is a simple sling or a figure of 8 bandage. That is what we all do. Nowadays we are in fact thinking of only simple sling. Even the figure of 8 may not be needed. So first, functional and cosmetic results are identical. Alignment of healed fractures unchanged from initial displacement. So nothing changes if you just give a sling, they unite and do well. So non-union, in the older study, near and one of the most famous studies on clavicle fractures, non-union less than 1% in conservatively managed, and it was 4% in operated patients. I agree, it may be because the implants were not as good as they are now, but non-operative treatment. But now there is new evidence. I agree. My friend will push me on this, that the new evidence has come, and non-operative treatment or displaced fractures is not as good as traditionally thought. I'm sure he will have a lot of references on that, and so that is what I want to grab the limelight from him. So this is the studies he would probably present. Deficits following non-operative treatment displaced fractures are quite a bit. Fracture shortening more than 2 centimeters may be predictive of worst outcome. But that is shifting the goals. Are we really bothered about these functional elements, that there is functional deficit of 5 to 10%? I am sure my own experience doesn't tell me that. So this is one of the biggest studies, Canadian Orthopedic Society study. So where they said it was a multi-center prospective randomized trial, level 1, 111 patients with 1 year follow-up, and they show faster union and lower non-union in ORIF group, and few symptomatic malunions. So the evidence is like there, but there are complications associated with these. So we have created newer complications: wound infection 4.8%, removal of hardware 8%, neuritis 13%, non-union 1.6%. So all this keeps on adding as you start fiddling with this simple bone. So then the current this that the strength of the injured shoulder was 81% of maximum flexion, 75%. So this is all statistically probably important, shifting goals that you want, because it was now uniting well with non-operative treatment. Now you can unite it with but better functional. So it is a very difficult assessment which we can say. So conclusion is displaced mid-shaft fractures can cause significant persistent disability even if they heal uneventfully. So that was the conclusion. So less than 5 millimeter shortening probably doesn't matter, more than 20 millimeters, but how often do we see more than 20 millimeter shortening? So surgery, as I told you, everybody thinks that maza aayega is a very simple bone exposed, but then the whole periosteal sleeve on top, on the superior surface, is the vascular supply of the bone. So once you are removing that, you are removing the periosteum, you are creating non-union. So unless you have been very particular, not going on the posterior surface, inferior surface, and just simply exposing, which is very difficult most of the times, and particularly when there is comminution, you will probably need to get them in good alignment, so you'll need to devascularize that and raise the chances of union. So whether you have a simple bump or you have these unsightly scars, that is your problem. So all dogs are not achhe, so you probably need to think about this, whether you need to operate on them. So simple fractures which can cause you a lot of trouble ultimately. Of course, I can agree that implants have changed now. We have much better implants now, much more rigid implants now. So implant breakage is not a problem, but then they can back out also. So you can have these very expensive implants, but they are not affordable. Can you afford it? So whether it is needed to be so aggressive on these things. So you have these slings which are available at 400 rupees, 300 rupees, while you have plates, clavicular plates, which are available at around 30,000 and 40,000 rupees, with the consequent complications of almost 4 to 8% of non-union rate, infection, removal of hardware. So whether it is all worth it, that's what I want to propose. So there is something called titanium elastic nails. People have tried this, probably this more biological, but then it is a difficult procedure. You can have a lot of neurovascular injuries if you're not well trained in this. So again, non-union 90% rates, but you can have malunion and you can have failures in these also. So my own experience, and we have presented this in literature, that most displaced mid-shaft fractures can be successfully treated non-operatively. Early fixation and comminuted fractures should be avoided. Your experience and patient needs may help you in taking right decision, and bony prominence is believed to be preferable to an unsightly scar. So union and ROM, or a patient, you need to talk to your patient. You need to read what is his need, whether he's an athlete, whether he's a beauty contestant, whether all these things can probably guide you how you treat these fractures. And a good discussion with the patient is what it all needs, because anything can have. It is clavicle. You can do it. You can mess with it. You can play with it. It is clavicle. It's just exposed. You just need to small incision and you can get it into alignment.